Pindy.
Hi, Poonam, you can hear me? Dr. Poonam, can you hear me? Am I audible to others? Can somebody confirm, please?
Yes, you're audible to me.
Okay.
Yeah.
So you're co-host now, Poonam.
Okay.
Try to share your PPT if you can.
Is it visible?
Poonam, screen is visible.
Invisible. Like my screen slideshow. Okay. Okay, I'm ready whenever you are.
We are already live, so we'll begin. Okay, we'll begin at 5:30 dot. We are already live.
Yep. Okay.
So good evening, everybody. I hope I'm audible to all. So today we are again restarting our PG masterclass, which we had stopped in June because of the PG exams. So today it's a very pertinent topic, both practically and theoretically, where we are going to discuss about strategies for surveillance of healthcare associated infections. And we have Dr. Poonam Lumba for this purpose. She is currently head of the department, microbiology at GV Pant Hospital. She is an avid educationist and medical microbiologist, and is also been an executive member with the national body of IAMM, and also is the current secretary for IAMM Delhi chapter. So without wasting any time, over to you, Poonam, for an exciting thing. We'll take the questions in the chat box at the end of this session. Poonam, you're muted.
Okay. Good evening, everybody, and thank you, Sonal, so much. We'll be now talking about the strategy of surveillance of hospital-acquired infections. It's a huge topic, and I cannot even start to cover the entire aspect. So I will only kind of give you a broad overview of what is surveillance, what is supposed to do with the key definitions and the basic process. Beyond that, I think Dr. Sonal has already planned a series of lectures in which she'll discuss some of them in more details. So I will just give you a broad overview of this topic. So the first thing we come to is, what is surveillance? This is a public health definition, and I'll first read the definition. It says that public health surveillance is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. Sounds very long-winded, but there are 3 or 4 main key points. One, it is an ongoing continuous process. It's never that you do surveillance today, stop it tomorrow, and decide after 6 months, maybe I need to do something again. You collect the data from the hospitals. And when we talk about it in microbiology, we talk about it for any other healthcare related event, say an infection, an outbreak, a prospective analysis, whatever. We collect the data, analyze it, come up with something, give it to the clinicians, implement it. So what data do we do and why is it needed? Because first of all, that you have to determine the burden and outcomes of HAIs using standardized metrics. HAI surveillance has been done by all of us at some stage. Some of you use our own criteria, some use something else, some do it on a clinician base. So if you do a surveillance properly using standardized metrics, you know exactly what is the HAI rate of your hospital and how do you compare with hospital ABC, nationally, regionally. And
Poonam,
yeah.
Can I interrupt? Your slide is not changing.
Not changing? Oh God,
and
second.
It's not in a full screen mode also.
1 second. I've just stopped it. I'm going to restart the slide share. Just wait. Okay, is it going to the second slide here? No.
Now it is what is surveillance, second slide.
Fine. So I'll just try it on the screen share. If it doesn't work, I'll just go on this then. Otherwise, it'll be kind of wasting time. Just let me know if it's gone on slide share and if it is moving.
Try to go to the next slide.
Here it is going. But let me just see if it is moving.
Now it's going. Now it's going. Now it's moving.
Is it on, so I'll just try on slide screen. If it's not going, tell me. I'll go back to this view.
Okay.
So is it moving?
Yes.
We are in business?
Yes.
Okay, fine. Yeah, so we're in business back again. Sorry for the technical glitch. So one, you have to determine the outcome of HAIs. What is the burden to compare yourself with the state or with the national level? Second, as a microbiologist, our bread and butter, identify the pathogens and the susceptibility patterns. Third, very important is that once we do it, we all are doing the antibiotic sensitivity, but what are we doing later? What are the strategies for implementing our HI rates? Today, my HI rate was 8.6%. Tomorrow, I'm implementing a strategy. Is my HI rate increasing? It is decreasing. What is happening? Is the patient mortality rate becoming better? The morbidity rate is changing. What is changing? So whenever we do surveillance, we get this very big impact on this platform. Another is we identify the potential risk factors with the HIs, because again, the strategies are based on the risk factors. If today you have an outbreak of, say, Acinetobacter in your ICU, so what was the risk factor? Was it the patient factor? Did it come somewhere from the equipment? Where did it come from? What were the risk factors? And of course, we have to give this feedback to clinicians because, well, they are the ones who want to put into practice. And for many of us, we do HIS surveillance and even on that note, biomedical waste management, because it's an inherent part of the accreditation process. Every accreditation process, these two are a huge component, whether we talk of kayakalp, whether we talk of quality cell, whichever one we talk of. So if the next slide doesn't go down, let me know. So it's a, so does the next slide come up?
No.
No, so I'm just shutting the full screen mode and I'm going to do the slide mode, this basic mode, because otherwise no. This is visible?
Now it's moving.
Let it go on this only then.
Okay.
Yeah.
Zoom it out.
Sorry. I'll just zoom it out.
Yeah.
Yeah. So it's a circular process. Your implementation is surveillance program. You disseminate the data, you analyze the data, you make comparisons, make decisions, evaluate the impact, again start collecting data, analyze, prevention, and evaluation. So it's a whole circular process which goes on. So what are the types of surveillance? One is active and passive. The HI programs initially start with passive surveillance. A clinician sitting in the ward, he sees these patients. Okay, in my ICU, I seem to have 4 patients who have a surgical surgical site infection, or I have maybe 3 patients with a UTI. So I report it somewhere and say I'm doing the surveillance. This was passive, where it started from. But I don't need to elaborate the inherent pitfalls. You don't get the data, it's not adequate, under-reporting, so on and so forth. So then the microbiologist and we said, no, this is not, we can't depend only on the clinician. Let us take in the onus of the whole thing. So now we have ICNs who go to the wards. How the ICNs go and what do they do? I'll come in the next slide. The second time we can do is sentinel event and population based. Sentinel is you're doing only on the basis of an event, which in most cases is an outbreak of infection. So it's individual, it's event based. It will tell you at that particular time, this infection, this is the data. So again, because it is limited, it doesn't give you the holistic picture. So we move from sentinel to population based, in which you survey the population, which is your patients with maybe similar risk, and you record it. This is what it is done. And of course, when we talk about it, it is you surveilling all the patients. So it is a huge amount of work, but population based ones are the ones which are being kind of done quite a bit. Then another way of saying the surveillance, how are you doing it is, whether you're doing it based on the outcome or the process. Both the terms are kind of interlinked. You have various processes which contribute to an outcome. For example, if your outcome is, say, surveillance of HAI, or if your outcome is, say, surveillance of antimicrobial resistance programs or stewardship. So if I go to the first example, which is surveillance of HAI. So I will see how many HAI I have, how many were surgical site, how many were this thing. So I just have the outcome. This was the H, these were the HIs. I don't have the processes. What contributed to the HI? That is process surveillance. So in this, I will see maybe hand hygiene. How did it contribute to hand hygiene, to infection? We know that whenever we talk about it, hand hygiene is talked always, you implement it properly, your infection rate comes to 50%. So the outcome becomes 50% less. So HI you probably will do bundle care in it. You might do other things. So these are the processes. You can even do surveillance of these processes. Your hand hygiene audit is a part of this thing. So this is outcome and process-based surveillance. Another one is, so these are the various surveillance methods which are there. Another is, these I'm just listing it out. There is no time, so I won't go into details. You could have prevalence or incidence-based surveys. You can have miscellaneous methods, rotation-based, risk factor-based, outbreak-based. All of these, you can kind of read about it. But the more important ones which I've discussed is the active and passive surveillance, which you should know. The second is the hospital-based or the population-based, and sentinel-based or which is based. These are the main surveillance methods which we do. Now, if you come to the next thing is, what are the various surveillance methods which we use, types of surveillance and the surveillance methods. So whenever we do the surveillance methods, which is the topic also called surveillance strategies in a way. So what are the strategies? I want to do surveillance in my hospital. So what is my strategy? Can I cover every patient? Can I not cover every patient? Who will cover the patient and how it will be covered? So one is hospital based. I'm covering all patients from patient number 1 to patient number 250 bedded hospital, 250 patients. But for all of us, when we have more than 1,000 bedded, 1,500 bedded, it's not possible to do a hospital-wise surveillance. So we move on to slightly, let's get more selective. Maybe you want to do targeted surveillance. So we'll specify location. You'll want to do a surveillance in an ICU. You'll want to do surveillance in OT. You might want to do surveillance in a high-risk area, in a cancer unit, transplant area, do it. So you specify by locations, specify by patients, the cancer patients, immunocompromised patients, patients who have gone some particular surgeries, patients with some other infections or procedure. Because you can't really target and do the entire hospital unless you have an extremely robust and a huge team to the whole thing. So that's patient-based surveillance methods. The second type of surveillance methods is team-based coverage on who is doing the surveillance. So originally it started with the ward license surveillance. You all just went to the ward, your ICS went to the ward, they saw, look at the case sheet number of a 10-bedded ICU, look at the 10 case sheets and say, okay, 5 patients have surgical site, 4 have this thing, and you kind of do the surveillance. But it was not quite adequate because underreporting, overreporting, missing out cases, so on and so forth. So then we said, okay, we can't really depend upon going to the ward and just seeing there. So now let's go to the lab. So I'm sitting in my lab. I have all the samples coming. I have hundreds cases of wound infection coming, 150 urine samples coming, so on and so forth, blood samples, everything coming. I say, okay, I have 100 blood samples today. This many came positive. So my rate is this thing. But again, this is keyword data because all patients, all samples may not be coming. And some samples which may not be positive may not be coming and not reflecting in my data. So this also doesn't really give you the complete picture. So the third thing which came up was lab-based ward surveillance. You get the patient requisition form. You see, okay, this is a patient, this infection, and you go to the ward and you do the surveillance. Again, you may miss out or may not miss out something. So now what most of us practice is laboratory-based ward license surveillance. What does this mean? It's laboratory-based. We are looking at the in requisition forms which comes to our department. The nursing staff takes that. But in addition, it is ward license surveillance. So the nursing staff goes to the wards. She'll go say to ICU 1. All the patients in the ICU 1, she will follow up prospectively. And of course, she has a laboratory form. So you're kind of trying to cover up all the patients which are there with the backup of the laboratory. So this is the most commonly used surveillance method, laboratory-based ward license surveillance. Okay. So you have others also. So these are some of the surveillance methods which are there. So now I have now currently just told you what is surveillance, why do you want to do surveillance, what are the surveillance methods, and what are the surveillance strategies. Now we come, whenever we do surveillance, you just can't just walk into the ward and say, okay, I want to do surveillance, so what do I have to look at? So there's few key terms whenever we talk about it, of which the first key term is present on admission. So it is defined as the infection is as present on admission if the date of event is on either of the first 2 calendar days, not 48 hours. Before we used to always say infection is present after 48 hours of admission. Here we say present on admission is if the patient has some event. He has fever indicating a UTI. He has fever indicating a BSI. He has a cough. So if it is present on the first 2 calendar days, it is called present on admission. So if you look at the slide, okay. So if you look at the slide, you have the patient come on May. So May 1 and May 2 is called present on admission. So going to the next term, healthcare associated infection, how do you define that? So the infection is defined as healthcare associated infection if the date of event is after the first 2 calendar days, that is 3rd day onwards. And in this figure, if it is there between May 3rd to May 8th. So it is after the first 2 days, first 2 calendar days, and it is called healthcare associated infection. If you look at this, there's another arrow which shows you date of event. I will come to the next one. So we've done 2 terms. One is present on admission, which is in the first 2 calendar days, and healthcare associated, which is from the 3rd calendar day onwards, not after 48 hours of admission. So the 3rd term which comes is called an infective window period or window period. Some books is written as window period, somewhere is written as IWP or infective window period. So I'll show you this in the next diagram. So it is 7 days time frame during which the criteria of the case definition must be met. So within 7 days, if you have say simply UTI, it is the time when you meet the criteria of UTI and includes the collection date. No, let me come to the next slide. I will explain it. Okay. So you have a patient who's come. Date of event is a day 4 in which for UTI, he probably had either a clinical feature of UTI or it was a day of the first diagnostic test. So let me just go back to the previous slide and now explain it to you. So it is 7 days time frame during which all the criteria of the case definition must be met. Second, it includes the collection date of the first positive diagnostic test, and it is within 3 calendar days before or 3 calendar days after. So you have an event happening. So 7 days period is the window period. Now, how is this window period and what is the date of the event which is happening? So date of event is a date at which the first element used to meet the HI case definition occurs for the first time during the window period. Going back 2 slides, day 4 is the day when the event occurred to meet the diagnostic criteria. It could be either a positive diagnostic test or it could be a clinical feature. So clinical feature could be fever, could be pyuria, could be dysuria frequency, whatever the feature of UTI. So either it is a day in which the patient had a clinical feature or it is a day of which you send the sample collection. The next line, it is the date of sample collection, not the date the test was performed, not the date which is reported. So date of event is a date of either getting the sample or collection of sample or appearance of clinical symptom. Explaining with an example. If you look at the example on the left hand side, so if day 1 is there, if you look at this, the first one, the date of event is on day 2. So it is now called present on admission because it's occurring within the first 2 calendar days. And the date of event is day 2. And this is it. If you look at the second one on the right side, you have the event occurring on day 4. So this tells you 2 things. One thing, it tells you that this is a hospital-acquired infection because it's occurring after 2 calendar days. The second thing it tells you is the window period. The window period is 3 days before and 3 days later. So this is the infective window period and date of event is here. So by now, I hope you're clear on what is date present on admission, what is hospital-acquired infection, what is date of event, and what is window period. The second one tells you all the 4. These 2 diagrams tell you all the 4. It will again come up, so I'll just revise it once again. So we come to yet another last 2 terms which are left. One term is called repeat event time frame. This is or an RIT. It is a 14 days time frame which starts from date of event, during which if the site-specific culture becomes positive again with the same or different organism, it is considered as the same HAI episode and not a different episode. To explain it again, so if you look at the slide, the patient came on 1st, on 4th, he has fever. Okay. So again, because he has fever on 4th, it is date of event is 4th. Okay. Which was done, which is there. It's hospital-acquired infection because it is after 2 calendar days. Here, if you look at the arrow in green, this is the infective window period, 3 days before and 3 days later. Now what I've said is repeat infection time frame. It starts on the day of event. It is a 14-day period, so it goes from the 4th and it goes up to the 17th. So it's a 14-day period from the start of date of event, in which here you had an event and you had E. coli in the urine, so it is UTI. Now, if on the 9th the patient is again having E. coli in urine, it is considered part of the same event. On 10th, again in urine he had Staph aureus, it is part of the same event and not a new hospital-acquired event. You do not do it that if you're having urine coming positive on the 6th and again on the 10th for different organisms, it is not two separate events, it is part of the same event and it is called repeat infection time frame. So coming back to the definition, it's a 14 days time frame starting from date of event, during which if the site-specific culture becomes positive again with the same or different organisms, it is same HI episode and not different. And you just add it to the case report and do not add it as a separate infection. This is called a repeat infection time frame. Another example to explain this. On the 1st, a patient came, no indwelling catheter, no indwelling catheter. On the 4th, the date of event, the patient had urine culture Staph aureus. So here, if you look, you have a date of event. From the 4th to the 17th, you had a repeat infection time frame, or the RIT, which I'm talking about, in which now the patient is also catheterized and he's again having E. coli coming versus Staph. But the diagnosis does not change. It remains a non-catheter associated UTI because the catheter has come up on day 5. It does not change the diagnosis. It remains UTI and it remains as a part of the same episode and not as a different episode. And it occurs during the 14 window period. Neither the location changes nor the preliminary or the primary diagnosis changes. So I hope you're clear on RIT. Now the most painful one we come to is the last one is the secondary BSI attribution period. This is, as the term suggests, it is for bloodstream infections. So what is this period? It is a 14 to 17 day period starting from the first window period till the last day of RIT. I'm just reading it right now. I explain it in the next example. It's a period in which the blood specimen must be collected for a secondary bloodstream infection to be attributed to a primary site infection. So now to explain. We are coming back to the same example. So on day 4, the patient had fever, date of event. The infective window period to repeat again is 3 days before and 3 days later. The RIT period was from start of the date of event till 14 days. Now, when I talk about secondary bloodstream attribution period, it is from the first date of the infective window period. So it is from the first and it finishes on the RIT, which is on the 17th. So I hope it is clear to you, all the 4 terms: date of event, window period, RIT is a 14-day time frame. At 3 days of the infective window period, it was 17 days time frame. This is the thing. So now what is secondary bloodstream infection attributable period? So in this period now, you had an E. coli coming on the 6th. And now you have a blood coming with E. coli on the 15th. So this bloodstream infection is attributable to the E. coli as it meets the definition of this thing. Let me come to next slide and I'll repeat it again in this one. So the BSI can be secondary if a surveillance site specific definition must be met. And just concentrate on the first one. At least one organism from the blood specimen matches an organism identified from the site specific infection, which is used as an element to meet the specific infection and the blood. Okay, let's go back to this. So if you have a blood में E. coli coming on the 15th, it is called secondary BSI infection in simple words because it is the organism is same. One organism must be common. You have an E. coli here and you had an E. coli on the 4th. So if one organism of the blood culture matches the original organism of UTI or the site-specific infection. Second, the blood culture coming positive could also be attributed to the UTI. So this infection is called a secondary BSI infection. So but if it doesn't meet the definition or the organism is different, it is not secondary, it is a new BSI event. I'm explaining here. Here again, you had E. coli in the urine on day 3, day 4. Blood culture on day 9 showed E. faecalis. So it was in the repeat event time frame. It did not change the diagnosis and it was secondary. It was due to the blood culture. But if you have a secondary bloodstream attributed now in the blood culture of Staph aureus, it could be because of some other cause, and now it is going to be considered as a new infection, not a secondary bloodstream infection. Just to make the difference clear, here you had blood in the E. coli, and in the urine you had E. coli and you had fever. So blood E. coli was due to the UTI. In this one, here you're having blood Staph aureus. It is not due to the urine which had E. coli. Previously you had E. faecalis, so this was secondary, but now this is a new infection and it's a separate BSI and a separate event. I hope this is clear, but if it's not clear, we are now going to come to class B. So we'll come to this in the individual events, but many of these definitions which are there do not apply to surgical site infections, and VA will deal with it later. So now that we know what are the various terms which use for surveillance of HCI, please remember that surgical surveillance case definitions do not necessarily mean the clinical diagnosis. Surveillance definitions are used to identify trends in the population, and clinical diagnosis are used to treat the patient. So to give you an example, you have a patient coming to the ICU. He had a central line placed on the 17th June. He had some infection on fever on 22nd June and sample grew Staph aureus. No evidence of infection, and after 22nd June, the date which the sample was taken, he was afebrile. So the clinician will say it is not a true clinical infection. I will say it meets the BSI case discussion definition and is included as class B. So there's a discrepancy between clinical definition and the surveillance definitions. They both are not the same. Never use them interchangeably, otherwise it will cause a lot of confusion. So once we finish all the definitions, so what do you do the surveillance? What are the samples you're going to select? What you're going to do it? So what are the surveillance places, or what surveillance is normally done for? We normally do surveillances for central line associated BSI, which is class B, catheter associated UT-COTI, ventilator associated events, and surgical site infections. I only have 20 minutes, so I'm going to kind of go slightly fast and cover only the main points. So what is class B? As you all know, it is central line associated events. So for UTI and class B, let me say both here only. The date the surveillance is done from the date of the central line insertion or the date of the catheter insertion for UTI till the next date of catheter remove. If the catheter is removed on the 5th, you do surveillance till the 6th of the month. Central lines, you know what are they? You know what is not included. So the key definitions whenever you do a class B surveillances, one is what is primary BSI. So it's also called an LCBI or a lab confirmed BSI, which is not secondary to any other infection. Secondary BSI is which is seeded from another body site, which I've already told you. In which the UTI example I gave, the BSI was seeded because of UTI. Secondary BSI attribution period, I already told you, the 17 days period in which it is attributed as secondary BSI. I have already told you this one. I'm not repeating it again now. So the only one point which is there is that you can also call it secondary BSI if the blood culture is only, say, a marker for a particular infection. Like for example, for osteomyelitis, you will define osteomyelitis because you're also getting it in blood culture. You may not be able to directly get something there, but blood culture is positive. It's like a surrogate marker for osteomyelitis or for dysphasia infection or for endocarditis. So that is also secondary. That's all I'm going to say about it. Class B needs to be discussed in another whole session. It's not possible to do more. So an eligible central line is that which has been in place for more than 2 calendar days. This is very important because once your ICN goes to do a surveillance, she has to know that central line got placed 1. So when do you term it as class B? What is the eligible line? And what is class B? So what is there? So class B I've done. Eligible central line I've told you. Central line days, the total number of days the central line is accessed. This is all that I can tell you about class B right now. The formulas used to determine class B, I'll come to the end. All formulas in one slide. The second is catheter-associated UTI. So key points, again, the same thing. And UTI is always considered a primary site of infection. It is never secondary. Bloodstream infection can be primary. It can be secondary. And it includes only Foley's catheter, no other catheters included. So COTI is, just pay a little bit of attention to this one. A UTI where the indwelling urinary catheter was in place for more than 2 consecutive days, similar to class B, it has to be for more than 2 days in an inpatient because you're doing it in a hospital on the date of event, with the date of device placement being day 1, and the catheter was in place on the date of event or the day before. The second thing is very important because if the catheter was removed, then you start calculating it from the next day. It has to be done. So it has to be in place in 2 consecutive days, and it has to be placed on the date of event or the day before. COTI, almost all of us know what are the definitions. The surveillance definition of symptomatic, or which is also called in places SUTI. COTI includes all 3 criteria. The catheter criteria, which I've just told you. Symptom, one of the symptoms of UTI. And the important thing is that when we talk about the urine culture criteria, it is usually only 1 or 2 organisms. More than 3, anyway, we don't report. And even when we report 1 or 2 organisms, it's important that the colony conforming count has to be more than 10 to the power 5. If it is less than that, then it is not taken as COTI and you do not include it in the definition. And for COTI, all the 3 criteria need to be now met, not just 1 or 2 of these criteria. So whenever next your ICNs go to do the surveillance, make sure that all of it is met, and don't forget the catheter being in place for more than 2 consecutive days. Asymptomatic bacteria, all of you know. So this is just a small snapshot of what you do. You have a urine culture. If it's negative, no UTI. If it's positive, whether the catheter was in place for more than 2 days or it was in place for less than 2 days. More than 2 days, symptoms present, it's catheter associated symptomatic UTI. Symptoms absent, then you look at the surrogate. Remember the blood culture in the sample which I've shown you. So if the blood culture is positive, catheter associated, asymptomatic, be a booty. So if it's less than 2 days, I'm not talking about it because my time is now running out. So now we come to VAP surveillance. Whenever we talk about VAP surveillance, many of you would be very familiar with this definition. Hospital-acquired pneumonia that occurs more than 48 hours later, in which we collected the clinical criteria, the microbiological, and the radiology. So now what was the issue in the whole thing? What was the problem in this thing? The problem is because it was highly dependent upon one radiology. X-ray changes. X-ray ढंग से लिया, नहीं लिया. It's visible on X-ray, not visible. Clinical criteria, was it reported properly? Case sheet went to see, was it done properly or not properly? Lot of problems. So there's a lot of variability in it. So in 2013, I think they decided, let's do with VAP, and now we come to VAE. I'm literally skipping the next 2 slides. So now we talk about VAE, and this is done so that you have a more objective criteria. So the important things is one, that here you consider the deterioration, the respiratory status after a period of stability or improvement on the ventilator. So we never considered that, and that here it is deterioration. Second, evidence of infection or inflammation. There we, in VAP, we used to do only evidence of infection. We didn't consider inflammation. Third, laboratory evidence. We did in that also. So the two main terminologies is fraction of inspired oxygen and positive and expiratory pressure. So fraction of inspired oxygen is the amount of oxygen which is in inspired air, which is normally 21%, and it is called as FiO2 0.21. So if our pulmonary function test is not going the patient ventilator, he requires more of it. So the fraction percentage increases. So that's increase in the FiO2. The second term is positive end expiratory pressure, which is a patient is on ventilator. It's doing ventilator-associated pneumonia, so he's on a ventilator. So it is the pressure which the ventilator uses to maintain the airway at the end of the expiration, that the airway stay open and do not collapse. That's normal positive end expiratory pressure. And it is usually 0 to 5, and after that only we say it increases, and increases usually more than 3, so which is more than 8, and it is measured in centimeters water. Beyond that, you have some more definitions, daily minimum FiO2, daily minimum PEEP, and a whole lot of more. We'll discuss it another time. So what did we do in VAE now? How do you see 3 things? Duration, the respiratory status, evidence of infection or inflammation, and lab evidence of respiratory infection. So the important thing, the definitions previous 3 days before, 3 days later does not work in VAE, that for the date of event, here the patient must be ventilated for at least 4 calendar days to fulfill VAE criteria, where date of intubation and initiation of mechanical ventilation is day 1. So date of event here changes from COTI and Class B, where you had it 3 days before and 3 days later, with a minimum of 2 days. So the minimum and the earliest date in VA is day 3 of mechanical ventilation. And now the last definition is baseline period. So it's a period of stability or improvement on the ventilator defined by more than 2 calendar days of stable or decreasing daily minimum FiO2 or PEEP levels. So patient of stability is basically on 2 days, his levels remain almost the same. That's a patient basic stability period. So now what do you do? If you look at this, your patient's mechanical ventilator day 1 to day 4, if you see PEEP, it is only gone from 0 to 5. 0 to 5, remember, I told you was normal. Day 5 and 6 increased. So more than 2 days of stability have gone, day 3, day 4. After that it is increased. So now it is going into VAC. Similarly, the third one, if you look at the second diagram, here on day 3, it is shown PEEP is 3, day 4 is PEEP is 5. But till 5 it is normal, so it's almost considered as stable for 2 days. So the date of event or the VAC starts from day 5. So that's period of baseline stability. Now that this one is clear, we'll go to the next one. I've already told you the first calendar date and the date of event. So what is VAE or ventilator associated complication? So after the stability, which goes on all, you have worsening, which is increased FiO2 and increased PEEP. So here we're seeing the deterioration in the respiratory criteria, which is the first one. So the first is ventilator associated complication. From ventilator associated complication, how does the patient go more downhill? He goes to infection related VAC or IVAC. So in addition to VAC, he now has a clinical criteria of any of the 4, and antimicrobial started and continued for more than 4 days. Not 1, not 2, not 3, more than 4 days. It now goes into the IVAC. So he has worsening respiratory and he has signs of infection. So the third thing we come to is IVAC plus the culture criteria. Now he also has culture. So this is called probable or possible VAP. Where inherently when we did the old definition of VAP, we did 3 things and finished it up. Now we have it a more objective criteria. So this is VAP, and now my time is getting over. So the last one is surgical site infection. I think I'm going to skip it altogether. Most of you know SSI and I don't have the time. I want to go now to the next thing. So, one breath. We have done What is surveillance? What is the importance of surveillance? What are surveillance strategies? What are the definitions we use in surveillance? And what are the infections for which surveillance is done? Now we come to the practicalities. We have to, or you have to go to your ward and do surveillance. Ab aap kya karoge? So, when will you do surveillance? Where will you do it? Who will do it? What data will be collected? How will it be analyzed? So, we have done targeted or laboratory based on surveillance. You start doing surveillance on the first date of the month and continued for, I mean, it's done, of course, every monthly. So you do it for a period of 30 days, monthly surveillance. Your ICMN will go to the ward and collect the data, the surveillance data, and the denominator. So she goes to the ward on the first of the month, and she will now collect clinical data, which is based on the surveillance forms. So if she gone to ward 1, give me an example. She goes to ward, the ICU 1, where you have 10 patients. She will note down on day 1, how many patients are on a catheter, how many are on a central line, how many have a surgical site, how many have a BSI. She will note down all the basic data. Then she will start seeing the clinical data to see what is the development, how many fit into class B, how many fit into COTI, how many fit into BSI, how many fit into surgical site. So she has a numerator form and she has a denominator form. She will collect the data for both the things. And they have forms for it. Let me just show you. I might have a picture. Okay, I have this picture. All of you is not a really great picture. It's become pretty much faded out. So all of you in your hospitals would have, or you should have, different forms for every type of infection. So she will, for every patient, if say patient 1 has a central line and patient 1 also has a catheter, she will fill the form for central line and she will fill the form for catheter, in which she will say, okay, central line, today, what is it? What was there? What are the clinical features? What happened? Or if it's like say ventilator, what is the FIOP on day 1? What is the FPEEP on day 1? Was there any antibiotic? Was any clinical feature? What is there? So infection wise, she fills up the form and she also collects all the denominator. The patient days, the catheter days, the central line days, mechanical ventilation days, so on and so forth. She has all the data. Now, after 1 month, you get the data. What do you do with it? You will now calculate all the rates. It's literally the same formula for all of them. The number of COTI cases divided by urinary catheter days, class B divided by central line, VA divided by MV, same definitions. Then you can also have more definitions. As you go more and more, you could have standardized infection ratio, you can have a device utilization rate, and many more such formulas. So with the help of all these formulas, you can now calculate what is the hospital-acquired infection rate for various devices in your hospital, and you can use this data further for your own hospital, for inter-hospital comparison, state comparison, whichever comparison you want to do. Important thing to notice, of course, there are much more important points in each one of them, but grossly, we do not include community-acquired fungal infections in surveillance. We do not include Candida in UTI. We do not do surveillance for Entero-Candida cons, except in pleural tissues. We do not do it in brain dent patients. And surveillance, of course, is not to be used for clinical diagnosis. So my time is now up. So inherently, I hope that after this thing, you can at least go back and define what is surveillance, what types of surveillance, what are the main few infections for which you do the surveillance, what are the main definitions, how you collect the numerator, how do you collect the denominator, how do you collect the HIV rates. And after this, of course, once all this data is done, it is compiled, you then take it to your clinician, tell him this is your data, implement these measures, and so on and so forth. So this brings me to the end of my session. And you can scan this QR code because most of the matter is from the CDC site, in which there's this huge, beautiful document on surveillance of infection. So you can just scan the QR code and go back and read about it. These were the other references for it. So I now come to the end of the session. If there are any questions, I will do it.
Thank you, Poonam, for a very enlightening talk. I am sure the PGs have benefited a lot. So if we have any queries in the chat box, This is for me to answer. We do not share the PPT, but the whole recording is available on the YouTube channel of PG Masterclass. So shouldn't be a problem in case you want to watch it again. So as a copyright, this thing we do not share the PPT with anybody. So if there are any more queries, can you please have them in the chat box? So Poonam, somebody wants to know again how to calculate number of catheter days.
Okay, so the denominator is that once you go, your staff is there, your ICN is going to go to the ward and calculate on day 1. You have 10 patients in ICU. She will note down 10 patients, how many of them are on a catheter. So at the end of the month, you calculate it from there. You have the denominator of total number of patients on the catheter at that time. And the numerator is out of those patients on the catheter, how many of them are getting the infection. Is there any other question?
There's one more.
One more. PICC, what is the full form? Please write it down. If it's peripheral line, no, you do not include it. In class B, we include only the central line, which are near the great vessels. We do not include any grafts. We do not include the peripheral lines. If that was what PCICC was.
For cutaneous inserted central
No, we only include the central vessels and the large vessels, which are the lines near the central lines. We don't include the peripheral lines.
All right. Any more? I think there are no more questions.
No more questions. I think it was too definition heavy for people to have any questions.
No, it was a difficult topic made very easy. So,
but I think actually
I
think for all of you, yeah. The only thing I would like to say is that for those who've read it, the document which I gave the QR code, do please go back and read it, because even in class B, there's so many things which I could not even talk about. Class B, SSI, there are a whole lot of more ifs and buts. If this is there, what do we do? Please go back and read the document, because there's too much more in it.
And this is the topic which can actually go on for 4 sessions and still will not be satisfied. There are so many controversies and there are so many interpretations of it. So I'm sure these children can now read up and on the references that you've shared, and we'll be good to go. So thank you so much, Poonam.
Thank you
for
so much.
taking this session for us. Thanks a lot. And thank you everyone for joining us.
Dr. Poonam, it was wonderful session.
Thank you.
I'm Lavina here.
Oh, okay. Okay. Thank you.
Thank you, Dr. Lavina. I think.
Thank you.
Yeah, thank you, Dr. Sonal.
Thank you.
Thank you.